exam 1 or exam 2, and that's why she came in. So what I end up with today will still be on exam 1, because you had the ClinMed lectures on it. So since I've done, so you've had ClinMed on endometriosis, right, dysmenorrhea, and the vaginal candidiasis. So all my stuff will be on there. Sorry, Oakley. She looked dejected. So this will end up, so after this, it goes on exam 2. Okay.
Oh, infertility.
Yeah.
She's keeping things together, clarification. If there is nothing else that is characteristic of a PA program, it's fluid. So you're saying that ClinMed stuff would be on the other, that you'll have, I don't think so. I think she's planning
said
it
all
on.
the lectures up until today are on the test, which would include this one.
Yeah, I don't think she necessarily went in and looked at all what I was going to do. She said if you've had a ClinMed that corresponds to what I'm talking about, then we're doing it on this one. Okay, makes sense. You don't want to have to go back and look at just
That's
the
why
part
we were all
of this.
extra confused. We're like, why would they all do this?
Okay, what did you learn about endometriosis? Endometriosis.
It sucks.
It sucks, okay.
Outside
Okay, endometriosis, what is it?
When tissue grows outside of the
Yeah.
What, which tissue?
Endometrial.
Endometrial tissue outside the uterus. So where is it going to appear? Okay, so usually local, but can it be anywhere else? Yes, I've seen it in the lungs where people come in vomiting blood and they go in and they find endometrial tissue implanted in the lung. Rare, but it's usually pelvic, abdominal. Okay, what else?
GI.
Okay, symptoms, how are they going to present?
Pain.
Mostly pelvic pain. What else?
Bladder, bowel issues with menstrual cycles.
Bladder and bowel, right? So infertility could certainly be one. Anything else? PCOS. Could be, I don't know that. Okay. How do men get endometriosis? They do.
I didn't
They
know
do.
that.
There's case reports of men with endometriosis. Usually men who are obese or have some type of chronic inflammatory or after a surgery. Who's had embryology? Okay. How would that happen?
The tissue all technically the same, but it's just called something different?
It's not the same, but
Starts from the same germline.
very similar. So you have Wolffian ducts, Mullerian ducts, and mesonephric. Those give rise to most of the GU reproductive organs in the body. Okay? So women, our organs come out of that Mullerian duct. Okay? Men also have vestiges of Mullerian duct. It degenerates, but the vestiges stay there. And so it's thought that especially in obese men where estrogen levels go up, it can stimulate those vestiges of the Mullerian system, and they develop endometriosis. So it's possible, but it's very rare. It's usually found once they biopsy. Men are having trouble, they go in, they remove tissue, and then they find out it's actually endometrial material. Okay. As well, women have vestiges of the Wolffian duct as well. So I don't know that it gives rise to problems in women. I don't know what that would be. Okay. So what are the big ways that we treat them? So symptom control is a lot of it. So pelvic pain control is big. Usually we're going to do it until the time that they want to conceive, okay, or they reach menopause. Surgery, how does it come to play? Okay, so in some situations where you've got adhesions or for some type of pain, they're going to go in and remove those. Because we can't affect the disease with drugs, we can only arrest. Okay? So those endometrial implants go through the same cyclical changes under estrogen and progestin that the endometrium does. So that's why they give rise to problems or to symptoms. They also, if they bleed, they cause an inflammatory response, then those adhesions, the body will come in and try to deal with that foreign material where it shouldn't be, and that's where you develop all the other pathology. Okay. Anything else you learned? Got it? Not extremely common, but common enough to keep it in mind. So the goals of therapy is relieve the symptoms, primarily pain, and that's what we're going to talk about today. And the other is quality of life. It's allowing women to go about their daily life and not interfere with their work, their social, their education, their family, whatever obligations they have. We want to suppress disease progression. So some of that goes to suppressing that endometrial growth. Because so you talked about some of the theories of why those occur. So what are some of the reasons why we think that endometrial tissue ends up outside the... Okay, so that's a common one, is backflow during cycles. Anything else?
Does it go through the fallopian tube?
Right, that goes with that backflow. The other would be is that other tissue being responsive to hormonal influence and giving rise to those implants. Anything else? You talked about 3 or 4 different theories.
She only really touched on the backflow one.
That's what most people think it is. Whether that is true in all cases is probably not the case in all, but probably common. Preserving and improving fertility, because a lot of these women are young, so this is going to start showing up in late teens, early 20s. And maybe later in women who, since we delay fertility a lot, they're going to come in and go, can't get pregnant. So using that, so that'll be part of your differential. So treatment options we're going to talk about today. What first is non-steroidals, is using that, and in that same principles we just talked about with dysmenorrhea apply. The second are the use of hormonal contraceptives. This has been a mainstay for 40 years. Usually they would do a laparoscopic investigation, examination, find endometrial plaques, and then what they were implants, and they would put them on continuous. At least this is, so continuous concept has been around forever. So they put them on for at least 9 months, reevaluate, or they would tell women, if you want to have a baby, start now, and get it out of the way, because they know the disease will progress. The other we're going to talk about are gonadotropin releasing hormone agonist and the use of add-back therapy. This is a very good therapy. It has lots of side effects, but management-wise, it is very good in terms of managing pain and at least arresting the disease. Aromatase inhibitors are down the line. We usually don't use them until we've gone through these other agents. And the last one is danazol, which used to be the gold standard. 30, 40 years ago, that was one of the first drugs we used after the oral contraceptives. But it's very androgenic, so its side effect profile is big. So it has fallen, because we have better drugs that are better tolerated, it's down now to probably the last choice. So non-steroidal, so I said it wrong previously. So women who desire pregnancy can use NSAIDs, avoid the COX-2, sorry about that, because they can prevent or delay ovulation, as all of them can, but those seem to be more so. Okay, so let's talk about the estrogen, progestin, and contraceptives. So these are considered first line for pain management. You're usually dealing with young women. Probably most of them desire some type of contraception, or we want them to be on a contraceptive until they are going to plan a pregnancy. So these drugs work very well. They're low risk. The side effect profiles that we talked about would apply here as well. The contraindications would apply here as well. You can use any form. I'd say oral has been the one that's been used in the past, but the patch and the rings have also been used. Usually you're going to use it in a continuous fashion. I know that some people have used them on monthly, but you have the risk that the symptoms will come back during that hormone-free week. So they're good because they suppress ovarian function, and so they also suppress those implants' activity. You're also suppressing endometrial growth, so likely you're not going to, if backflow is really truly the mechanism of this disease, you are arresting that. So in theory, you would be arresting disease progression because more implants are going to be used. So you can use them long term. So that's a plus. When we get to the GnRH agonists, that becomes a problem with them because they are so powerful. And then you get the additional benefits. So think about, you get decreased risk of ovarian and endometrial cancer. Did they talk about endometriosis being a risk factor for ovarian cancer? Okay. I don't know how strong that tie is. I know that it is mentioned, but I don't know if that is a true cause and effect. So a lot of it, based on what product you choose and how you choose to give it, is going to be based on patient preference. And then response, you may have to change. So what if they don't respond? You're going to keep them on the NSAID if needed, and it would be more of a PRN. Keep them on the combination product, but what if that doesn't work? Well, try a different product, try a different route. If you went with maybe a ring, then change back to an oral agent. Another one that's down there is listed are the progestin onlys, which are pretty good in this disease. So the oral norethindrone is the mini pill, the micronor, progestin only pill, and it's very effective. We're going to see it pop up here a lot in different ways. The other is that you can put them on Depo-Provera, which would be an injection every 3 months. So lots of options. If one doesn't work, you can try another product or a progestin only. There is some data on cyclical versus now continuous. I'll come back to you. And that continuous in some studies has shown to be more acceptable and maybe provide a higher relief, pain relief. That may go to the type of patients who are using it. So if you've got patients in your study that are more high, severe, higher pain frequency, that may be what is influencing it. So in lower pain, less extensive disease. If a woman wants monthly, cyclical, then it's a reasonable thing to try. But I would say if they are more moderate to severe, I would recommend the continuous. Yes.
Would you consider changing the dose of an oral product or just changing the drug?
No, there's no. I've not seen anything that says use the higher. Most use they recommend anywhere from 10 to 50 micrograms of estrogen. Okay, so the 10 is pretty low. I would probably start with the 20 microgram per tablet. The progestin does not matter in this regard. You would only change a progestin product if the woman was having side effects, just like we did when we put them on for a contraceptive means. Okay, questions about those? Okay, let's look at the progestin products. They inhibit endometrial growth, so eventually the implants as well as the endometrium will atrophy. So that's when we use them in women for contraceptive, that's why they eventually become amenorrheic all the time. So they're very good in this case. The ones that are used mostly in this country are majoxy progesterone, that's Depo-Provera. But they've also started using the subcutaneous, so you could use the IM or the subcutaneous product. That's the every 3 months. Or you can use the Micronor, the norethindrome, which is a daily tablet. The doses are listed there. The one good thing about using the oral, either oral medroxyprogesterone or the norethindrome, is you don't get the bone loss. Remember that black box warning I told you about on Depo-Provera? If you use it for more than 2 years, you can get bone loss. So with the oral agents, that's not as much of a problem. Neither is VTE as much a problem. So clot risk is less with the orals than with the injectable. Okay. I know Laura Reinhardt also talked about second line being the IUDs. Okay. That is probably in practice what people do. I can tell you in the guidelines, at least in literature, it's considered an alternative. It's probably something people try because it's that women want it, or it's a good contraceptive product, but I can tell you there's not data behind it. So any of the IUDs that have progestin in it, you wouldn't use the Paragard in this case, the copper. So these have limited data. The good thing is that they're not going to affect bone mineral density, they're not going to affect clot risk. So they may have a place for women who have limitations in that area. These are really good. You see it says 80 to 100% of women are going to get relief. So these products are really good. But again, they don't do anything to change the disease. Once you take them off of it, the disease will come back. So again, you're going to use it until they either want to become pregnant or they hit menopause. Okay, ADRs here, the side effects are the same as what I gave you for oral contraceptives. So I didn't go through a laundry list of those, but it would all the same would apply. Okay. Any questions for, this would be probably ones you would more likely see. So let's talk about severe symptoms. So now we're going to ramp it up and we're going to go higher up the axis and we're going to affect at the hypothalamic area with a GnRH agonist. Some people have used the GnRH antagonist, but mostly in this disease we're going to use the agonist. And true to the complexity of endocrine, it's the same thing here. So you know the GnRH is coming from the hypothalamus and is stimulating the anterior pituitary, right? To put out the pituitary gonadotropins, LH, FSH. But look at the difference in terms of how you give it. So the GnRH antagonists, we know, are going to antagonize the effects of GnRH on the pituitary. Okay, that's a given. But look at what the agonists do. It depends on whether you give it in a pulsatile form or continuous. So when you start these drugs, you will get a surge of LH and FSH for a period of time, for a couple of weeks. And then because you're continuously bombarding that organ with GnRH, it will downregulate receptors. And so then what you get is a negative effect, and the FSH and LH will go to very low to 0. You can approximate a chemical menopause with these drugs. Their FSH and their LH will go to menopausal range. They'll be very hard to detect. Okay. So we've seen this in other places. We've seen that when you continually bombard a tissue, you downregulate receptors. Remember the picture I showed you is that you constantly have receptors being engaged. So remember what happens is when those receptor and a ligand, like a hormone, interact, what does the body do? What's the response? It can, but to get to that, what it does is it usually, remember the internalization of those receptors, And so then the intracellularly, it will disassemble those, and then it will it'll recirculate them up. That takes time. So that downregulation goes a lot to the internalization and how fast it can get it back up. Okay, so that's part of what's going on here. So when we give these products, we're going to give them continuously instead of in a pulsatile fashion. Pulsatile, we'll use that in other diseases for treatment. So that's an important distinction, and why it's important to tell women that about adherence. Because if you take it off, if you remove and you're non-adherent, you give the pituitary time to recover, and the LH and FSH will go back up. So you can see why this is for severe pain. So we're going to put these women into menopause. And within 4 to 8 weeks, they will have menopausal symptoms. They'll have hot flashes, they'll complain, vaginal dryness, everything that we talked about with women in their 50s. These women in their 20s will start to experience. So for that reason, if you use them alone, you can only use them for a short period of time. Because what's going to happen to bone? It's going to go down quickly. Okay. This is all in there. I'm just giving you a dialogue, a verbal summary. So there is a processor, so you can use it for 6 months by itself. But what a lot of people do now is they do GnRH plus add-back. And there's a picture, I think, in your handout of this. So the add-back is saying, okay, we're going to add back a small amount of estrogen or a small amount of progestin that will keep you from being symptomatic and will preserve your bone. And then we can use this for a long period of time. Okay? So there are reports of using this kind of combination therapy for 10 years or more. Because you've taken the steps to keep the woman comfortable but also preserve bone. So let's see, let me catch you up where I am on my handout. So if you look on page 11, that mechanism of action is what I walked you through, and that refers to that picture underneath there. The good thing about this is it's very reversible. So when you stop it, the axis will return. Most women's cycles will return within 3 months. So that's the good thing. So if they want to become pregnant, plan a pregnancy, they can still do it on this product. It will not return as quickly as what they would if they were on oral contraceptives. So on page 12, let me catch you up here. So 12, there are the products at the top of that page. Leuprolide, nafarelin, and goserelin. These are the 3 that have an FDA indication for this. They're approved for 6 months of continuous use, again, by themselves. There is you can repeat it for an additional 6 months, but it should never be used beyond 12 months without add-back because of the effects we've already talked about. So if you look down through those, what you'll see on the dosage form is you've got 3 different forms, so that's nice. You've got a nasal spray, if women don't want to go with injectable. You've got Leuprolide, which is an IM depot. It's monthly, whereas the spray they're going to have to administer twice a day. And then you've got the implants, subcutaneous implants. And there you've got 1 month to 3 months, depending on the dose. Okay, so that's great. So women have a choice as to what they want to do. Signs and symptoms of hypoestrogenic state, we've talked about these. It looks like menopause, amenorrhea, vasomotor symptoms, urogenital atrophy, so atrophic vaginitis, vaginal dryness, dyspareunia. These are young women, probably many would be sexually active. Decreased libido, mood swings, headaches, accelerated bone loss. Okay, so that's all the stuff that's going to happen with these. Some people have tried alternatives if they don't want to use add-back therapy, is they have gone with lower doses, or they have lengthened out. Instead of giving like Lupron every 4 weeks, they might do it every 6 weeks to attenuate the effect. Okay. So add-back. So if you look at this picture, it's on the next page, page 13. So the thought here is this is where you would initiate, this is not showing up. Can you see the mouse? No. Okay. If you start at so you've got on the y-axis you have estradiol levels, and on the x-axis would be time. So at the very beginning of time, then that's when you are starting the GnRH. You are dealing with women who are in the reproductive years. Their estradiol levels are going to be pretty high because their ovarian function's intact. Then you see where they start the GnRH agonists, you get that upswing because you are increasing LH and FSH, mostly FSH, so you get an uptick in estradiol. That is short-lived, it's less than 2 weeks usually. And then you get a drop because you have cut off any stimulation of the ovaries by FSH and LH. So look at where estradiol goes to. And in that 4 to 8 weeks is where those menopausal symptoms start. So the add-back, small amounts of estrogen or a small amount of progestin, brings it back up enough that the menopausal symptoms go away and bone is maintained. You will find providers who do this very same thing if they're going to use Depo-Provera, long-term for a contraceptive. Eventually what they'll do to preserve bone is they'll add back a little estrogen. They'll give them an oral estrogen. To me it defeats the purpose. You know, you might as well take continuous. But if you don't have to take a pill every day, you still have to with the estrogen. It's the same time of concept. We don't see menopausal symptoms with long-term progestin, but you do get the bone loss because the estrogen's your major player there. Okay. So options, if you look at the bottom of the bottom there, you can use Micronor, that's the norethindrome, or you can use an estrogen-progestin combination. There are 2 on the market that are commonly used. Primpro, which you see is the combination of conjugated estrogen and medroxyprogesterone. They're using these products for menopausal women because the dose is lower. So they're getting away with the ones that we would use for contraception would be higher. So that's why they're doing it. And the comma patch is also used more often in menopause. Okay. On the next page, just from my reading, it looks like norethindrome tends to be preferred as an add-back compared to the other products. If you look below that picture, you'll see that with Lupron and Micronor, that is actually an FDA-approved indication, so they've gone after that in terms of pelvic pain and endometriosis. Let's see if there's anything under there. The so other things, vitamin D, calcium, making sure that those are either in the diet or supplement is important. So the estrogen and the progestin, so you might start there. If they didn't tolerate that, then you could move to the estrogen progestin. Let's see. I think I've said everything that's below there. Next page, concurrent versus delayed. Some people will, so you could do that. You could use a trial 6 month of the, as long as they can tolerate it, of the GnRH only, and then use add back later. So all of that works, and mostly what they're doing there is their target is bone health, bone maintenance. The alternative that I talked to you about, either decrease the dose or extend the interval, can also help mitigate the side effects. Duration. Let's see if there's anything different here. Look about halfway down. Here would be monitoring bone mineral density in these women would be important on a periodic basis. They're recommending initial 6 to 9 months. Let's see, that bone density be obtained after 6 to 9 months and then every 2 years. Insurance usually doesn't pay for that, so this would be one of those that may require justification. They're pretty tight on what they will pay for in terms of those bone mineral densities. So in small clinical trials, this add-back therapy has been used for 30 months up to 10 years of treatment. So these would be women who either are not surgical candidates, don't want surgery, let's say they're 20 years old, they're going to delay pregnancy for a longer length of time, for whatever reason. Then this is a good alternative. Now, because you are using progestins, they're androgenic, right? You've got to monitor lipids. So this may not be a group that you necessarily would monitor lipids in. So monitoring their LDL will tend to go up and their HDL will tend to go down. If you throw the estrogens in there, their triglycerides may also go up. Another therapy that I didn't put in there, you may make a note, is some people are now using bisphosphonates to maintain bone health. Now here's the worry. In women that were using it that are in their 50s, 60s, we're not worried about them becoming pregnant. Okay? So bisphosphonates, what did I tell you in terms of half-life? How long does it stay in the bone? 10 years, okay? It leaches out. So the worry has been that if you put a 20-year-old on it and they want to get pregnant, that now you've got that bisphosphonate, okay, that's leaching out that can then get to the fetus. At this point, there has been no reports of congenital defects from that or that causing problems in pregnancy, but just keep that in mind that people are using that therapy and that has been raised as an issue. Okay, questions to that point? I think it would be unlikely you would see this unless you are in a GYN practice or you are in a practice that would deal with women having these problems. Maybe surgery, I don't know. Not sure where they would show up outside. Okay. Aromatase inhibitors. So aromatase inhibitors, we've talked about products that are a result of aromatase. So what does this look like? Where is this coming from? Where is this taking place in the body? Adrenal what? Cortex. Okay. So remember, we started with cholesterol as our primary substrate, and we went to that first part is that upper layer, so that's glomerulosa. When you get down into that golden box, that's more the reticularis, that's that most inner layer because that gives rise to your sex hormones. Okay. So you see aromatase is important in converting testosterone to estradiol, androstenedione to estrone. Okay. So we can use an aromatase inhibitor to stop that. Okay. So that's where they come. You're not going to see them used very often. These are going to be in more refractory cases, can't use other products. Typical treatments are with Arimidex or Femera would be the common drugs. The disadvantage is that you get bone loss because you've lost estrogen. in cyst development. It can be used in combination with a GnRH agonist or with the combination oral contraceptives. So usually used with other agents. So an add-on for refractory. The last one on the page 15 is danazol. Again, I saw Laura Reinhardt in her PowerPoint put down, it was the gold standard, and it was for years. This was the most effective drug we had. But again, because it is very androgenic, it has fallen down to this lower last end. But it's very effective. It's very good at suppressing implant development and all the symptoms that come from it. It's now recommended to limit it to 6 months of therapy, and again, to use it if all other therapies have failed. Side effects are dose dependent, but it's all the androgen: weight gain, muscle cramps, decreased breast size, hirsutism, oily skin, acne, all of those. So I think that is it. Questions about the drugs? A difficult disease to deal with, and can last a woman 20 to 30 years. Usually once they go to menopause, then it arrests.